Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome back to episode 2 of the Emerging Evidence in Myasthenia Gravis podcast series. I'm Dr. Nick Silvestri, and today I'm going to take a deeper look at innovative therapeutic agents, notably complement inhibitors and FcRn antagonists. I'll unpack the science behind complement inhibitors and FcRn antagonists, explore real-world data, and highlight new findings from the 2025 American Academy of Neurology annual meeting. Whether you're managing newly diagnosed patients or supporting those with refractory disease, today's discussion will give you practical, clinically relevant updates to apply in your practice. Let's set the stage. Historically, MG treatment has revolved around 4 major strategies. First, symptomatic relief with acetylcholinesterase inhibitors such as pyridostigmine. Next, broad immunosuppression with corticosteroids and agents like azathioprine or mycophenolate mofetil. Next, rescue therapies such as IVIG or plasma exchange, principally for acute exacerbations or crises. And finally, thymectomy in select cases. While effective for many, these approaches are often slow-acting, nonspecific, and fraught with side effect, especially with steroids. And that's why recent years have seen a shift towards precision therapeutics, targeting the immunological mechanisms specific to MG. Enter complement inhibitors and FcRn antagonists. So let's first talk about complement. The complement system plays a central role in the pathogenesis of AChR-positive MG, where antibodies activate the classical complement cascade, leading to destruction of the postsynaptic membrane. Eculizumab, the first approved complement inhibitor for MG, blocks complement protein C5, preventing formation of the membrane attack complex. The landmark REGAIN trial showed significant improvements in MG-ADL and QMG scores, reduced exacerbations, and improved quality of life in patients with refractory acetylcholine receptor positive MG. But there was a catch: biweekly infusions, high cost, and the requirement for meningococcal vaccination due to increased infection risk. Then came ravulizumab, a long-acting C5 inhibitor offering maintenance dosing at every 8 weeks. At AAN 2025, new real-world registry data confirmed sustained efficacy and improved adherence with this less frequent regimen. Patients reported better convenience, reduced infusion fatigue, and fewer missed workdays, which are key quality of life metrics. Zilucoplan is a self-administered subcutaneous C5 inhibitor. This was another hot topic. In the RAISE trial, zilucoplan led to statistically significant improvements in MG-ADL and QMG scores within 2 to 4 weeks. At AAN 2025, follow-up demonstrated the following. First, rapid symptom control in newly diagnosed acetylcholine receptor positive patients. Second, consistent efficacy across bulbar, limb, and ocular symptoms. And finally, a low rate of serious infections with appropriate prophylaxis. The key takeaway? Complement inhibition has evolved from niche rescue therapy to a frontline option for acetylcholine receptor positive myasthenia gravis, especially when rapid symptom control or steroid sparing is a goal. Let's now move on to FcRn antagonists. Another breakthrough has come with agents that lower circulating IgG, including pathogenic acetylcholine receptor or MuSK antibodies. The neonatal Fc receptor, or FcRn, normally protects IgG from degradation. By blocking FcRn, drugs like efgartigimod, rozanolixizumab accelerate IgG clearance, reducing disease-driving antibodies without broader immunosuppression. The ADAPT trial showed that efgartigimod improved MG-ADL scores in acetylcholine receptor positive patients within 2 weeks of initiation. Importantly, around 70% of responders did not need daily immunosuppression during the trial. Efgartigimod is administered intravenously every 4 weeks in cycles, with retreatment based on clinical need. At AAN 2025, an extension study of real-world patients showed durable response even with intermittent treatment cycles, patient satisfaction with flexible treatment cycles, and fewer infections compared to traditional immunosuppression. Moving on to rozanolixizumab, which is given subcutaneously weekly and cycles are 6 weeks apiece. This was also spotlighted. The MyCaring study demonstrated meaningful improvements in both patient-reported and clinician-assessed outcomes. At AAN 2025, abstracts demonstrated the following: efficacy in older patients and those with bulbar predominant disease, significant improvements in ocular symptoms, including ptosis and diplopia, and a promising safety profile with low rates of serious adverse events. Additionally, new phase 3 data on nipocalimab, an investigational FcRn blocker, showed robust improvements in both AChR-positive and seronegative patients, an important step in expanding treatment access to a broader population. Let's now talk about route of administration. One of the most important patient-centered themes at AAN 2025 was the emphasis on route of administration and patient empowerment. Self-administered options like zilucoplan offer reduced need for infusion centers, greater independence for working patients, and flexibility for travel or remote living. The implications are clear. Where clinically appropriate, self-administered treatments can significantly improve patient satisfaction and patient engagement. Now let's talk about when and how to use these agents. Let's bring this to clinic. When might you consider initiating a complement inhibitor or FcRn inhibitor? Newly diagnosed patients with acetylcholine receptor positive disease and severe disease, patients with suboptimal response to steroids or immunosuppressants, frequent relapses or steroid dependence, MG crisis prevention in high-risk patients, or patient preference for rapid symptom control or minimal side effects. Timing matters too. Several presenters at AAN 2025 advocated for earlier initiation of targeted therapies before extensive steroid exposure to minimize long-term side effects and disease burden. Now, safety remains a top concern when starting any new therapy. And here's a quick summary of what to watch for. In terms of complement inhibitors, this really requires the administration of meningococcal vaccine, ideally 2 weeks before starting. Monitor for signs of infection, especially in the first month. For FcRn antagonists, these are generally well tolerated, but you need to monitor for mild to moderate headaches, upper respiratory tract infections, and infusion reactions. There was no increase in serious infections reported in the long-term data to date. And finally, with IVIG and plasma exchange, use caution when overlapping these therapies that reduce IgG levels or interfere with FcRn function. So what did AAN 2025 teach us? Let's recap some key learnings. First, zilucoplan is effective across all muscle subdomains and is now approved for self-administration. Ravulizumab offers every 8-week intravenous dosing for patients and reduces infusion fatigue. Rozanolixizumab shows benefits in ocular and bulbar symptoms with weekly subcutaneous administration. FcRn antagonists may eventually play a role in seronegative MG pending further trials. Nipocalimab phase 3 results are promising and may expand the toolbox for clinicians. And finally, that earlier use of targeted therapies leads to better long-term outcomes, including fewer hospitalizations, improved functional scores, and reduced steroid use. So let's wrap up with a few practical tips for integrating these therapies into your workflow. First, stratify your patients based on antibody status, symptom severity, and prior treatment response. Second, consider early initiation of targeted therapies in moderate to severe cases, especially in those with acetylcholine receptor positive disease. Next, discuss self-administration options with patients who travel or work full-time. Monitor and educate patients on vaccine requirements, especially when using complement inhibitors. And finally, collaborate with specialty pharmacists to navigate access and reimbursement for high-cost therapies. Thank you for joining us for episode 2 of Emerging Evidence in Myasthenia Gravis. We've covered a lot here, from the mechanism of action behind new therapies to administration preferences, safety, and real-world findings from AAN 2025. In our next episode, we'll explore the critical role of serotype testing in guiding treatment decisions, including how it impacts care for patients with MuSK and LRP4 antibodies. Please return to the homepage to claim your credit. Until next time, stay current, stay compassionate, and keep leading with evidence.